right, guys, we are moving on to Chapter 10, Anti-Tubercular Drugs. So these are your drugs that are given. So we kind of included with antibiotics. These are antibiotics, but we're talking about them specifically because the treatment is very, very specific in regards to tuberculosis. So we've talked about, we all pretty much admitted, or some of us admitted, that we don't always finish all of our antibiotics for the whole 10 days. You know, we're not always beautifully compliant with that whenever we get to feeling better and we forget, yada, yada. So anti-tubercular drugs, you think it's hard to take drugs for 10 days. These drugs are given, the course of treatment is very, very long, 6 to 12 months. And we'll go into the specifics for that in a little bit. But you can imagine that these patients are not always wanting to be super duper compliant with these drugs. So we're going to talk about what drugs are used. You do need to know the specific drugs that are used for tuberculosis, and you need to know the difference between latent TB and active TB, and we're going to talk about that a little bit. And then we're going to talk about, you know, how the chart on page 109 is just, it's a beautiful, you know how I tell you, like, if you can memorize this, you will be in tip-top shape. This is kind of one of those charts that's incredibly important to know. So let me just go with the PowerPoint. Don't get anxious if I go through it quick, because again, we've talked about some of this stuff already. So tuberculosis, 1/3 of the world's population is infected with TB. So that's pretty solid. In the United States, it is not that significant as it is in other parts of the world like Asia and Africa. But TB still causes approximately 1.5 million deaths a year, and that is solid. So so it's still important that we teach, and it's still important that even though we live in a country where it's not as prevalent, it could very easily be. So TB is most common in people who live in crowded areas. It's especially noted in people who have compromised immune systems, like HIV. So whenever someone's immune system is compromised, things that, you know, we can often fight off, kind of like if you think about the coronavirus. It's a virus, so just go with me for a minute. You know, everybody got real anxious when it came out, and it is a big deal and it is important, but your biggest at-risk population were the people who already were predisposed. You know, they already had heart issues and lung issues. Those are the people who were most at risk for, you know, fatality related to the coronavirus. It's kind of the same thing with tuberculosis. Your people who are immunocompromised and debilitated are at greater risk for death related to this. Primarily, in regards to what it does to your body, it primarily is a disease of the lungs, but it can affect other areas of your body. And that is noted on that chart in page 109. It can affect your spleen, your liver, your adrenal glands, your vertebrae, your lymph nodes. When it has gone outside of your lungs, it is especially, it's even more dangerous. It's kind of like, it's not the same thing, but if you think of metastasis with cancer, you know, it's bad if it's in that one place. It's really bad if it's outside of that place. Same idea with TB, okay? All right. Only about 10,000 people in the U.S. have it, so of course it's not bad. And individuals who travel globally can become infected. So people who are going to Africa, going to Asia, all of these other things, we want to make sure that they're aware. And one of the biggies that you need to know is that it's caused by it is transmitted through droplet transmission. So a regular old mask like this, not cutting it, not doing anything, okay? You have to have an N95 mask that you're specifically fitted for, and your patients are going to be in negative pressure rooms in the hospital setting, okay? So we have two different, okay, so this is where I don't want y'all to Food health, if I could talk. This is where I don't want y'all to get confused. There is latent TB and there is active TB, excuse me. Of active TB can be classified further into primary treatment and secondary treatment. Okay, so I don't want y'all to get those all discombobulated. So before I talk about primary and secondary treatment, I want to talk about standard treatment and preventative treatment. So standard treatment, okay, so standard treatment is going to be for the person who has active tuberculosis. It is in their body, it is alive, and they are infected. They are ill, they are infected with it. These people are treated for 6 to 9 months, and the drugs that they're treated with are INH, rifampin, ethambutol, and paracetamide. Okay, those are your drugs that they're treated with. If a patient only has latent TB, if they test positive, that means the infection is living in the bacterium is living in their body, but it has not infected their body. They are not actively ill, but it's just kind of in their body hanging out, and it's waiting. It's waiting to say, okay, oh, look, they're a little bit immunocompromised, let's get them. So we treat these patients with preventative therapy, and it is only generally one drug. INH is that drug. Sometimes it is rifampin instead of INH, okay? And depending on your physician, depending on, there's other factors, it'll always be one of those 4 drugs at least, at minimum, of the ones that are used for standard treatment. The most common is INH. The second most common is rifampin. And it is taken for 6 to 12 months. So if you get a TB skin test and it comes back positive, and you get a chest x-ray, so that chest x-ray will be used to determine if this is a latent infection, and it won't show up on the chest x-ray, or if it's an active infection and it will show up on the chest x-ray. So those are the kind of diagnostics that are going to determine our treatment. So when we're talking about standard treatment, that's the first 4 drugs that I talked about. If they are reinfected, that is secondary treatment. And they are going to, those are there's even additional drugs added to those other drugs. They're more expensive, and they're more toxic to the body. I think we get into those drugs specifically, but the main ones that I want you to know are the ones that we're using for standard treatment versus preventative therapy. Know that if we're treating them with secondary drugs, then either primary treatment didn't work, they're resistant to primary treatment, or their TB infection has spread extrapulmonary. It's outside of their lungs. And like I told you guys earlier, kind of like with the metastasis, if it's outside of the lungs, then we got to be a whole lot more aggressive, okay? And it's affecting other organs. So let's see what else. That's the biggest thing. So let me go on to the next slide and tell you what else I want to tell you. So latent TB, they're infected with the bacteria, but they don't have the disease. They come back with a positive skin and blood test. And I've discussed with other instructors. I want you to take this right here where it says not infectious. Take it with a grain of salt. So in regards to your exam, your book very specifically says that people with latent TB cannot spread it to others. It very explicitly says that in the box on 10.1. But I know that in crowded areas, they've thought that this is why it spreads so rapidly. And also, a lot of times if people are being treated prophylactically, preventatively, they'll have them wear an N95 mask. So technically, according to your book, and probably according to the latest guidelines from the CDC, it is not infectious in its latent stage. but it's possible. And the other reason, about 5 to 10 people who have latent TB will become active. So that N95 mask may be more of a preventative measure, like a just in case insurance policy kind of thing. But for test purposes, latent TB is not, cannot be passed, to another, to someone else. We talked about it. They're treated with INH for 6 to 9 months, and sometimes treated with rifampin weekly for 12 weeks. All right. I've already told you all these drugs. This is the chart that's on page 109. And if you look at it, it's 6 months total. So the initial 4 months, they will be treated, the initial 2 months, they will be treated with all 4 of these drugs. And then they will all fall off except for rifampin and the INH. And then that will continue for the next 4 months, making it a minimum 6 month treatment. Retreatment, these are the additional drugs for retreatment. They're going to fall into that secondary treatment category that we discussed. All right. Specific adverse reactions related to ethambutol is optic neuritis. So if they start complaining about their eyes changing, their vision changing, all of that is going to be something that you're going to take into, you're going to make sure that you're making note of that. We're not going to use it. We're going to use it very cautiously. If we know that it can have an effect on the eyes, we're going to use it very cautiously in people who already have cataracts or diabetic retinopathy or any of these other conditions that affect their eyes. All right, INH causes some of those typical nausea, vomiting, epigastric stuff that we've talked about. And we're not supposed to give it to, it can cause toxicity if we give it with foods that are rich in tyramine. So, or tyramine. Y'all know I say a lot of stuff wrong with my country self. I apologize. But those things are found in like pepperoni, salami, beer and wine. I kind of think of bar foods like nuts, cheeses, aged cheeses. That is a very serious, and you'll see tyramine, it'll be a drug-food interaction that we'll see a lot moving forward, but it can interfere with INH. All right. These drugs can be hepatotoxic. So we're going to watch those liver function tests, and we're going to make sure that our patients aren't jaundiced in appearance. All right, and then rifampin, some of the biggies that you need to take, write down, keep in mind. Reddish orange discoloration of body fluids is definitely going to be seen with rifampin, and that is, people are not nearly as alarmed if you give them a heads up. Your pee is going to turn orange than if they go to the restroom and they're like, oh my gosh, what's happening? It can cause contact lenses. It's not just the urine, other body fluids as well. So it can cause a little bit of discoloration to contact lenses. You don't have orange stuff running out of your eyes, obviously, but it can cause some of those changes. And it can also cause some vertigo, in addition to those epigastric issues that our other antibiotics are causing. We want to, when we're assessing the patient with latent TB, active TB, I keep saying TB, BBB, we want to make sure that if the patient has active TB, we need to know who they've been in contact with. And the CDC follows all of that stuff very closely so that they can do tracking and, you know, kind of see where is this spreading, where is it coming from, what exactly is going on here. And then the biggest thing is compliance, you know, instructing that you know, this illness is life-threatening, you know, this infection could cause death. It's very, very important that you finish your antibiotics. There's something even called DOT, direct observation therapy, and that's going to be where somebody is giving them those medications daily to ensure their compliance. And nursing diagnoses, it's going to be all related to that assessment. Acute pain could be from excessive coughing, imbalanced nutrition could be related to the medications that they're taking causing epigastric discomfort, risk for ineffective self-health management. That is your non-compliant patients who are not following their recommended course of treatment. And then I believe I've told you all of this stuff already. Just making sure. If they're getting anything parenterally, y'all know to rotate injection sites. Explain that short-term therapy is in no value in treating the disease. So this is not one of those things they can be like, oh, well, I took it for 3 months. That's better than nothing. Not really. Because that infection is not eradicated. It is still present in the body without following through on this full course of treatment. And that is also contributing to the fact that these medications are becoming, these mycobacterium are becoming resistant to the medications that we have. And at the end of the day, we want them to be compliant. We want them to verbalize understanding. We want them to manage their medications appropriately. And that is it for your TB drugs.